Can I please have your attention? It is now 6 o'clock. Can you take your seats? We are now going to begin. Thank you.
Hello, everybody. Hello, everybody. So I want to try to keep us all in time because I know that many of you showed up here for different portions of the agenda. So I want to try to start on time so we can end on time. So I want to first go over just a little bit of logistics and some thank yous before we get the event actually officially started. So I first wanted to just say a little bit about logistics. I want to welcome you all to our Community Healthcare is a Human Right MLK Day Observed Forum. We are here today to talk about healthcare as a human right, and we also are here today to show you a little bit of how we envision healthcare as a human right. Conversations from all around the state, people talking about the social determinants of healthcare, people sharing their stories, their healthcare stories, their tragedies, their hopes, people questioning the system that we currently have. Our youth, very important as we talk about the next generation. What will healthcare look like for them? Many different providers from all around the state, like today, helping us to do these health screening clinics. Many different providers other than medical providers helping us to do these clinics. So tonight is the sixth of a series of events across the state designed to continue the conversation about how our universal system, Green Mountain Care, will work for us. We're going to start the conversation tonight with a few notes on how we got here and the point we are entering now in terms of creating a healthcare system that meets human rights standards. Today, as we celebrate the life and legacy of the Dr. Martin Luther King Jr., I want to remind us all that while Dr. King is celebrated for his leadership of the civil rights movement, his nonviolent vision was also rooted in human rights. When he wrote, "Injustice anywhere is a threat to justice everywhere," he was expressing the universality of human rights, something we apply to healthcare in calling for a universal system without systemic barriers to care. Again, my name is Sheila, and I became a part of this movement because I believe healthcare is a human right. I stay a part of this movement because I too have experience. I often do not get the preventative care I need because I can't afford it. I watch my friends lose their homes, go bankrupt because of one unexpected illness, one unexpected accident. I watch my neighbors suffer to access care because their particular ailment is not covered under the insurance. I watched my suicidal family member literally be put against insurance system. I've watched members of my community die, not only because of lack of health care, but simply because it was unaffordable. I want us all, after I say this quote, to just take a moment of silence and to remember that we're not just here to have a forum, that we're here to honor a legacy of a great leader, Martin Luther King Jr., and all the leaders that helped lead with him. And those leaders are now us today, and we have to carry that torch. So after this quote, I would like to just have a moment of silence in his honor. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Martin Luther King, in a speech to the Medical Committee for the Human Rights, 1966. We can just give a moment. Thank you. So as we continue, I'm going to say a few more quotes from Dr. Martin Luther King Jr. that I feel is really prevalent in this circle. When we look at a modern man, we have to face the fact that modern man suffers from a kind of poverty of the spirit, which stands in glaring contrast with the scientific and technological abundance. We've learned to fly the air as birds. We've learned to swim the sea as fish, yet we haven't learned to walk the earth as brothers and sisters. Perhaps no part of our society shows the glaring contrast King is talking about better than our healthcare system today. We have the technology to ease suffering and to cure diseases in ways that past generations could never dream or imagine. But yet we still haven't ensured that all people have access to even basic health care. The Affordable Care Act was a good step towards a more just U.S. healthcare system. Maybe something that the King would have approved much of the law, which dramatically improves access to the care for poor and people of color. However, he also said, we must accept finite disappointment, but never lose infinite hope. Some of us were disappointed that the health reform didn't go further. It wasn't single payer, it didn't include a public option, and by excluding undocumented immigrants, it won't provide truly universal coverage. But it was progress. But now we are here in Vermont because of your help. We are leading the nation in bringing the first universal healthcare system that is equitably financed to the country. And we know that healthcare is a human right, and we know that Vermont can lead the way. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. King was talking about civil rights in this letter, but it's also pretty good judgment for health care for all. So I want to now bring up my wonderful team that we have today to moderate. And for all the panelists that are here, can you please come up to the front right here? Would be really appreciated.
So my name is Ellen Schwartz. I live here in Brattleboro, and I had a chance to talk to some of you back at the health screening clinic. I got involved in the healthcare as a human rights campaign in 2008. And the main reason I got involved is that I truly believe that we all have a right to health care, and that if people can get needed care, that we'll all be healthier as individuals and also as a community. I had personal experience with this when I lived in England for 2 years, and I was on the National Health in England. And I experienced at that time firsthand what it was like for people to not have to worry about getting sick. In fact, people in England would, when they would ask me about this country, they couldn't believe that people lived in a country like the United States with all that it had to offer and had to worry about that. Whatever else they thought about the national health, everybody liked the fact that they didn't have to worry about getting sick. They also didn't have to worry about being able to access preventative care. And patients and providers, it was a very simple process. You went in, you didn't have to deal with a multitude of insurance companies and the cards and the papers because everybody was on the national health. As a result, there was a lot less bureaucracy and a lot more effort and money going into actually providing health care. Back in this country, as a public school teacher, the issue of health insurance was always contentious when it came to contract negotiations. And the question that I would hear over and over from members of the community is, why should I contribute to your health care? Because members of the public were contributing part of my premium. Why should I contribute to your health care when I don't have it for myself? And all I could say is, you should have it. And so when this movement started, it seemed like it was an opportunity to put into practice what I had been saying, to really make it possible for everybody to have access to health care in Vermont. And that was one of the reasons I jumped on board. As Sheila said, we're going to give a little bit of background at this point to sort of get everybody up to speed to where we are now in 2014. So in 2008, we, the Vermont Workers Center, launched the Healthcare as a Human Right campaign. And the idea was to really change the conversation about healthcare and change what is politically possible with healthcare reform. We conducted thousands of surveys around the state and petitions, forums where we put the current system on trial and found it guilty. We did political education, we held legislative forums, rallies, we were a presence in the State House, we had regional organizing committees and still do, a human rights framework, we make our own media, and by simply talking with our neighbors, we have changed what's politically possible. We've changed the idea that healthcare is a commodity to the idea that healthcare is a right and a public good. In 2011, much of this work came to fruition in the political arena with the passage of Act 48. This was the groundbreaking law that said that Vermont would be the first state to design a healthcare single-payer system as a public good, a system that meets the human rights principles of universality, equity, accountability, transparency, and participation. Thanks to the Vermont Workers Center and the many people across the state who made their voices heard, including many people who are in this room, Act 48 holds our new healthcare system to these human rights standards. Now, in 2014, the task before us is to make sure that decisions about our new system are based on these principles, because we know from experience that when we make decisions based on profits, our communities suffer and our health suffers. For example, the current system is not universal because many people are left out or cannot get the care they need, such as dental, as Diana mentioned, or vision care. It's not equitable because those of us with little money have greater difficulties in getting the care we need. It's not accountable because we can't hold insurance companies responsible for ensuring access to care. It's not transparent because we don't know how important decisions get made that affect our health. And it's not participatory because generally we're not a part of making those decisions. So as we move toward our universal system, we must change all that. Act 48 requires that all Vermont residents have access to comprehensive, appropriate, and medically necessary health services. It prohibits systemic barriers to accessing care, and it requires that the financing of our new healthcare system be shared equitably among us. Healthcare must be provided as a public good, which means that it must be publicly administered and financed. Everyone involved in designing our universal system should be guided by human rights principles. Those are the standards in the law by which all decisions must be made. Our experiences of the healthcare crisis demonstrate why this is so important, and the law that we passed recognizes that. So, how do these principles apply to the two key decisions that lie ahead of us at this point? One of those decisions is how will we decide on the financing plan for Green Mountain Care, and the other one is the range of health services that we can get. The principle of universality requires that all Vermont residents get the healthcare services that they need without systemic barriers. And the principle of equity requires that these services be financed equitably, with contributions from individuals and corporations based on their ability to pay rather than the amount or type of care that a person needs. Our healthcare system must have one primary purpose: to ensure that the people of Vermont are as healthy as possible. To achieve this, we must change the system in two key ways. One is we must focus on care and not insurance coverage. And the second is that we must provide health care as a public good, financed equitably as mandated by Act 48. So these are the two questions that we hope to focus the conversation on tonight: care, not coverage, and equitable financing. And with that background, I'd like to introduce Lynn Akey, who's another member of background.
Good evening, everyone. I have been in the movement going on 3 years, thanks to Sheila. I didn't even know anything about this. And I am so happy that I am in this movement. And everyone works so hard. They are so dedicated. And I am so proud of everything that currently we are in a transitional period for health care. As required by Affordable Care Act, Vermont has created an exchange where residents can purchase health insurance. Some people are eligible for financial assistance to help pay for that coverage. While this new law has new consumer protections, it is designed to get more people to purchase insurance. In that way, it is just more of the same, a new way to deliver health care as a commodity, not a human right. Tonight, we will focus the conversation on getting to universal care and not on the exchange. Now on the agenda for tonight, next up, we will hear a few testimonies about the current system from people in our community. Maddie Salmonen and myself, Lynn Akey. After the testimonies, I will briefly explain what we mean when we say care, not coverage, and equitable financing. Then we will pose two sets of questions for our panelists to respond to. We also want you to have a chance to ask questions of the panelists. There are index cards on the chairs and tables. If you have questions for any of the panelists, please write it clearly on the card and indicate which panelist your question is addressed to. Sheila and George will be collecting the questions. Could you two please raise your hands? Now I'd like to introduce our moderator, Spoon Agave.
Thank you, Lynn. I'm Spoon Agave, probably fairly recognizable for my involvement over the years with municipal affairs. I'm here as a member of the Vermont Workers Center, and an organization I have tremendous admiration and respect for, and consider them the single most effective grassroots organizing happening in the state right now. I'm also here because I have a very deep interest, very strong interest in the Healthcare as a Human Rights campaign. Healthcare, of course, has always been very important to me, but I never thought about it so much as I did about 2 years ago, when the only health care available to me was Medicare. And for a person who is fairly intelligent and well-educated, I have to say I had never run into any program that was so confusing and just beyond my comprehension. The parts A and B and C and D, and that part B didn't cover everything, and you needed more insurance from any one of a list of other private health insurance who offered you another whole list of plans to choose from, and drug plans, I didn't know what was going on, and I only got through it, and a little advice, through the organization Senior Solutions, which were a big help. They gave me superb advice, got me hooked up with the right people, and I was home free until a year later when I began to receive Social Security and found out too late that a program I had been on through the state that helped me to pay for the gap insurance was no longer covering the gap insurance. And I didn't really realize, because of the types of mail that was coming through it and that the premium payments I was making hadn't changed, that I no longer had that insurance. Now here I am without that insurance and having health problems. So it's just, I just look around me and I know that Vermont must have universal single-payer health insurance. Now, I would like to introduce our panelists for this evening. On your left, Richard Davis. Richard is a registered nurse, reformer, well-known, I hear, reformer, columnist, and longtime advocate for healthcare reform and single-payer in Vermont. He was a founder of the Vermont Citizens Campaign for Health. He and Darrell Pillsbury run the Heat Fund, which addresses another unmet need in our community, heat to get through the winter. On his left is Robin Lunge, the Director of Healthcare Reform in the state of for the State of Vermont Agency of Administration. She oversees and coordinates healthcare reform efforts across state government and serves as a liaison to the Green Mountain Healthcare Board. And to her left is Onye Hawkinson. Onye is a naturopathic physician and founder of Heartsong Health and Community, a nonprofit naturopathic clinic that is committed to equitable access and nonprofit health care. Heartsong was certified as a Level 3 patient-centered medical home in the Vermont Blueprint for Health. That is Vermont's statewide initiative for health care and reform. Thank you all very much for being here. At this point, I'd like to bring up a few people, three, in fact, that we have. One you have met a moment ago, Lynn, and two others that will share just a few minutes of their own personal health care stories.
My name is Lynn Akey, a citizen of Brattleboro, a member of the Vermont Workers Center and Put People's First campaign. I would like to thank the panel and the community for coming here tonight and taking the time to hear about our health care reform and how the members of Governor Shumlin's administration did not include dental and vision in our benefit package. I'm here tonight to say we want and need dental care in our universal health care coverage. This is about our quality of life. We can't afford not to have dental. Let's think about the meaning of the word universal. Refers to, applies to all, or a whole. Our teeth are a part of our human body, a very important part of our body. In our society today, there is a huge concern with obesity, diabetes, and heart disease. Dental is a serious concern, and proper dental benefit care should be in that packet. Dentures are not just for cosmetics, as the chewing of our food is the first step in proper digestion, and to be able to eat healthy foods, such as raw vegetables, fruits, and nuts, is so vital in our nutrition. Our diet has a significant influence on our overall health, and the health of our teeth and gums can cause serious health risks. Eating healthy, taking care of our bodies, will cut down on obesity, diabetes, and heart disease. The smile we present impacts every corner of our world. from personal to financial, job opportunities, and to be good physical health. It affects every fiber of our world. It's just good old common sense. It is my belief that no one should be refused health care or proper medical treatments because they do not have private health insurance or meet the criteria for public aid. It concerns me of what is to come for my grandchildren and other youngsters now facing this uncertain future. Our voices need to be heard. We need to fight this battle for dental and vision and get this into our universal health care packet. So we shall not give up the fight. We shall not give up the fight. So please put people first. Thank you. Now I'm going to introduce Jackie Gould.
Hi, I'm Jackie, and I just wanted to mention mostly, I have a lot of things I could say about healthcare, but I'm going to focus on one, which is the irony and vicious cycle of trying to get healthcare. I have a hidden disability, and because of that hidden disability, I actually qualify to get Medicare. However, I live afraid that I'll get better, because if I get better, I won't get Medicare, and then I'll get sick again. And I am sure I am not the only person in that situation. And it's a very sick and crazy system that makes you have to be extremely sick in order to get any help. And then if you start getting better, you lose the help. So I want that to be on the record that that's why we all need healthcare all the time. Because I don't want to live in that irony. I know that when I had the privilege of visiting my son when he was traveling overseas, and it goes to stress too, this woman came up to me, it was in Italy, and she said, "You Americans, you are so stressed out," and that's part of, people walking around with anxiety, depression, all those things that that's one of the things that contributes to mental health and self-esteem and all those things that make you a healthy individual. She said, "You Americans are so stressed out," and of course I could agree with her, but I said, "What do you mean?" And she said, "Because in our country we may complain about our taxes, but we never worry about losing our homes because our children go to college or because we get sick." And that just, I carry that around with me, and it was so powerful to hear that. Because, that's what our taxes should pay for everyone to have equitable health care and a place to live. And all of those things go to our mental health, our stress level, and the way we carry ourselves in the world. And we deserve, each and every one of us, to have the dignity of health care.
Now I would like to introduce Maddie Salinan.
Thank you. For 10 years of my life, I believed I had a rat in my brain. In that time, I made multiple suicide attempts, was incarcerated and involuntarily committed to a psychiatric hospital. I have schizophrenia. Today, I'm living a full and productive life. The adversity that nearly ruined me now is an asset. From it, I've gained a voice. From it, I've gained a purpose. I have witnessed the shortcomings and successes of the mental health system. I've been both harmed and aided by those there to support my recovery. Right from the time I was diagnosed with schizophrenia, the mental health system failed me. The psychiatrist who diagnosed me gave me a prescription and sent me on my way. No follow-up visit, no real concern for my well-being. A couple months after receiving a schizophrenia diagnosis, I attempted to take my own life. First by cutting my wrist, but after failing, I set plans to hang myself. I tied a noose and hid it away. Fortunately, someone found it. Fortunately, I'm still alive. A doctor I spoke to assumed, like many would, that I had attempted this suicide due to emotional distress. However, the real reason I attempted to take my life was not emotional. It was based in fear and paranoid delusion. I believed that people intended to do serious harm to me. I believed that suicide was a way out, but my doctor didn't question his assumptions. If he had, he and I could have done real work to resolve the distress that plagued me. Resolution to my confused state of mind did not come until I began working with peer specialists. Peer specialists are people who have faced the challenges of mental illness, have recovered, and support others who are afflicted with mental disease. It was 4.5 years after receiving a schizophrenia diagnosis before I met my first peer specialist. No one in that time really understood me. They medicated me and even impacted me so that I may get better. But there is no college degree that will help you understand a person suffering from mental illness as much as you would from having been there yourself. Our mental health system is currently housing too many people in jails and psychiatric hospitals. I can say from experience that this is because we are too reactive in treating mental illness. The current system of mental health care does not adequately address mental health challenges until there is impending danger or legal entanglement. Then the treatments administered are generally an imposition and sometimes harmful. We must aggressively utilize peers to both educate and support those diagnosed with mental illnesses. We must end the era of a repressive mental health system that stigmatizes and marginalizes those who it is there to heal.
We have just heard 3 stories, very meaningful, very powerful, very moving, from members of our community about their own challenges in obtaining the care that they need. The aim of our healthcare system should be to keep people healthy. Health insurance is not health care. Insurance is just a means of enabling us to pay for health care. Health care is the actual care that we receive from our providers. The way things are is that insurance companies are simply entities that exist to make a profit in the delivery of health care. An insurer's only purpose is to make a profit from every service or transaction that they cover. It has no inherent interest in what a community actually needs. No matter how much or how little your insurance covers, it is still based upon profiting from everything it does for you. The consequence of this is that the cost of health care has become astronomically expensive. And the consequence of that is that there are huge numbers of people without adequate resources who never get the health care that they need. We must shift the paradigm from coverage to care. We must move into a new era where our healthcare system is based on people's needs and not a company's profits. We must abandon that old system that is in fact preventing us from having adequate health care in our communities. We must develop a healthcare delivery system based on the human rights principle that every person is entitled to all the health care that they need. Now it is your insurance company that decides whether or not you receive health care. They in effect make that decision by deciding whether or not they will pay for it. This makes no sense. The care we need is a decision that can and must only be made between our doctor or provider and ourselves. It is absurd and unconscionable that it could be made by someone who may be thousands of miles away and is first and foremost concerned with how much profit they will earn from the services provided. A universal system places people's health first. It uses public resources to provide health care for every person. Everyone needs health care. Everyone needs preventive care, oral care, hearing and vision care, mental health care. We are whole beings. We need total care, and that is what must be provided by our healthcare system. However, the insurance industry doesn't want to pay its profits out. And that is why, in a system run by insurance companies and profits, it's often hard rather than easy to receive care. It's why so many people have little, if any, care at all. We need state policies that place health care at the same level of importance as the need to have food and clean water. Only then, with a universal health care system, will we be proactively providing care for a lifetime of good health. Only then are we respecting our humanity. Let's work together to figure out how to build a healthcare system that provides access to everyone and all of our needs. Let's dispense with a system that, for the sake of earning profits, provides us with as little care as it can get away with. Universal care, wherever it is in place throughout the world, has proven to be effective and far less costly. The financial burden of universal health care must also be spread equitably. There can never be allowed an instance when the lack of money would prevent receiving care. Even small copays or fees can be a barrier to a person with little or no means or resources. They can discourage seeking health care among those who may need it most. The principle of equity requires that those who have the most contribute the most. Public financing through progressive taxation can achieve this end and provide health care for every person in our state. We must recognize and understand that health care is a human right. It is non-negotiable. This is a new way of thinking. The old way is not working. Too many people are without sufficient care. To put the health of our people first, we have to come together and recognize that our health is a human right and a public good. Therefore, its cost should be shared equitably by us all. No more insurance benefit packages, no more premiums, no more copays. Yes to our community needs. Yes to equitable financing.
So thank you, Spoon, for starting the conversation on both the type of care that we're going to have access to and how we're going to fund Green Mountain Care. Now we'd like to ask our panelists to respond to a few questions. We're going to start it off with a few questions, and we're going to ask each of you to keep your responses to around 2 to 3 minutes, so that there's also going to be time for audience questions. And to help with this, Sheila will give you, or Kate will give you a little signal when you have about 30 seconds left.
Okay, I am not an experienced moderator, so I will be doing my best. This is a question for Richard. As a healthcare provider, can you tell us what you would see as a system that provides care, not coverage?
What I have to say about this question is I can't answer it. So what I'm going to tell you is that we have asked these questions for decades, what we'd like to see in the system, and I think that it's the wrong question right now. I think the right question right now is how can we move forward? We've made some progress, but how do we move forward? So what I'm saying is we need to recognize the fact that nothing happens, unfortunately, nothing happens in healthcare reform outside of politics. And I think the Workers' Center has realized that, and I think most other groups have realized that. So if we really want to see a system, you can't talk about the elements of the system, we can't talk about the coverage. We've already talked about it. I think we already know what the basic elements of that coverage are. That's been determined pretty much. What we need to do is put more energy into pushing the political system harder and harder so that we move forward. So rather than, and the reason I say this, I want to make this clear, I'm not dodging this question. I'm trying to be realistic, because if you've worked within the reforms, the arena in Vermont any period of time, what you learn to understand is that no matter what you want to see and no matter what you formulate, it hardly ever comes out that way. What happens is you end up compromising, you end up moving very much more slowly than you ever expected to, and you don't quickly get to where you want to go. I mean, I've been doing this kind of work for almost, 25, 30 years, I don't know. We've made some progress, but I just wanted to make this one point right now, is that if we spend our time delineating what the care should be, then we're not going to make any more progress. We need to be as political as we can, we need to push forward, but those kinds of details, essentially, I think are a waste of time right now to talk about.
All righty, thank you. Richard, would you pass me?
Yes, Onye Hawkinson. I'm just sort of thinking about this question. The question posed was, what would I see as a system that provides care and not coverage? And first of all, I would like a system that provided both. But what it would look like might be something different than what we actually have now. However, one of the pieces, I agree that there are a lot of politics involved. I agree that we've got a long way to go to move the political agenda in a way we'd all be happy with. What I do want to say is that Vermont's actually done quite a bit already. And what I think is missing is that I don't think you folks know what you've actually got available to you already and how to get it for your own care. So, and the other piece, and I'll say a little bit about that, but the other piece I want to add to this is that I don't think that health care is about what somebody else brings you. You're the person who actually is responsible for your care. So there needs to be, for us to move forward, it's about everybody really understanding that your health is yours. Learning how to advocate for yourself with your doctors that you have now to get what's available, but also to develop ways of living that you don't get sick in the first place. And this is not going to be solved by the system outside. So when we talk about universal care, I'm talking about universal self-care. How can we take care of ourselves?
Yes, Annie. Thank you for saying that.
Well, but the other piece of it is not everybody has the tools and the knowledge to know how to do that. So if the question is, what would a system look like that had care and not coverage, the system would have as a priority educating us on how to take care of ourselves and providing us the support to do that. So that's two things I want to say right there, and that's probably my 2 minutes, right?
The next question I direct towards Robin. Can you tell us how the administration plans to implement the new focus on care, not coverage, and delivering health care as an equitably financed public good?
Sure, thank you for that question. My name is Robin Lunge. I'm the Director of Healthcare Reform for the state of Vermont. I work in the governor's office. And thank you all for coming out tonight, and thank you to everyone who shared your personal stories. I think this is now my 5th out of the 6 forums, and I think the stories are one of my favorite parts of being able to come to these community events, because you really get to hear something from each person. So I'm going to try and move on so I don't use up all my time saying thanks. So we have several initiatives that are currently going on right now to move forward with Green Mountain Care. This legislative session, we will be spending a lot of time talking with our friends, the legislators, about what work we've done over the last 2 years and moving forward with planning around Green Mountain Care. There are 2 big things that are happening right now. The first is on to address the care portion of the question. Vermont was very lucky in that we received a large grant from the federal government to help work with healthcare providers on moving forward on how we provide healthcare to Vermonters. And that's work that is being done in a collaborative process to promote patient-centered medical homes, such as the one that Annie runs, as well as moving towards a system where we provide financial incentives for healthcare providers to focus on care and not focus on fee-for-service reimbursement. So the way we pay for healthcare today is we do it as piecework. So when you go to the doctor gets paid. When you need a prescription, that costs money. And so each step along the way, there's a fee associated with it. What we would like to do is move to a system where we come up with a different way to reimburse providers so that they are supported as an infrastructure and that they can really focus on providing the best care for those patients and not necessarily have to think about every little bit of billing that is going to make sure they can make ends meet and stay in business. So that's one piece that's currently underway now and is moving forward over the next 3 years. The other big piece that we're working on is the financing proposals. We will have several financing options that we'll be talking with the legislature about this spring. So you'll start hearing more about those after town meeting week and over the summer. And the purpose there is to move from a premium-based system like we have today to a publicly financed system where we pay, everybody contributes and everyone is covered. That is going to be, in part, a scary political conversation because people don't like to talk about taxes. But I think the really important thing to remember is that the taxes that we're talking about replace something that you pay now in the form of a healthcare premium. So with that, I'm sure I'm over time, so I will stop talking until the next question. Thanks.
Okay, thank you very much, Robin. Our last question is for everyone. We can begin with Richard and just work across the table or down the table. What are the obstacles to achieving these goals? And how can we overcome these obstacles?
Well, I see the obstacles on two levels. One's on the ideological level, and the other one is on the practical level. So we're talking philosophy and money, basically. So, unfortunately, what we haven't done as a society, not only in Vermont but across the whole country, is we haven't had a big conversation about what we believe healthcare or a healthcare system, if it's ever created, which we don't have now. We haven't had a big public conversation about what we believe the guiding principles should be. We've had bits and pieces come out. Canada has had a number of these national forums, and that's why they've been able to, and keep in mind, Canada doesn't have one system, it's all provincial systems, but at least they've had this national conversation, and they've been able to determine fairly well what they think Canadians really want in terms of equity and justice in terms of healthcare. We have never had that conversation. So until we do, I think we're at a real loss to really move forward. So I consider that a big obstacle. The next obstacle is on a much lower level and it's not really the money. It's more about sound bites and spin than it is money. The money's already there, and as Robin said, any system that we develop will require taxes, but every study that I've ever seen indicates that we really won't be spending any more money than we do now on healthcare, but we will be calling something new taxes. And so our people who don't agree with us, which is generally, I'm talking about Republicans, conservatives, anybody who just doesn't want this because they want to continue the free market commodity-based system of healthcare, they're going to look at the tax thing and they're going to turn it around and say, look at what are you doing? You're raising new taxes, and they're not telling the whole story. So I think the obstacle is not that the funding's a big problem. The obstacle is the spin and the rhetoric and the politics of the money. But I think the money's already there, but that's you know, so it comes back to politics, like I said.
Thank you. I think what I would add is one of the obstacles is certainly fear. People are afraid of change. I think we've seen a lot of that with the Affordable Care Act for folks who were impacted. There's a lot of worry about how that was going to roll out, and I think that that is something that we all have to work together to reassure folks that, you know, we wouldn't be doing healthcare reform to break the system. We have a broken system, and we really need to figure out a way to improve it and move forward, and that requires change, and change is scary. But if we're thoughtful and we and transparent and we talk about it, then we can get there together. I think the other, and I totally agree with you around the money's there, it's paying for it differently, and when you pay for it differently, then that will shift how individuals pay, and so it gets very personal. Healthcare gets very personal very quickly, and one of the other educational obstacles is a lot of people don't actually know what they pay for healthcare today. They may know their portion that comes out of their check. They don't necessarily know what their employer contributes if they have employer-sponsored insurance, or if they're on a government, a currently publicly financed program, like for example mine, the state employees. You all don't know what you're contributing towards my coverage. I don't know what you're contributing towards my coverage. I know what I pay, and because of my position, I know what the employer pays. But that's another, I think, challenge, because the first question people go to is, but how does it compare to what I'm paying now? And if you don't know what you're paying now, it's really difficult to make that comparison.
You know, I can't speak to the whole money piece. I would like to think it's there, and someone's got to figure out how to get it where it needs to go. But I do agree that the biggest obstacle from my perspective is, as Richard said, ideological. But what I also know is that Vermont may not have had the conversation about what the ideology is going to be, but it has selected one. So the Vermont Blueprint for Health the government legislature has designated that as the entity that's going to be overseeing care. They have in turn chosen the National Council for Quality Assurance and their model for healthcare, which is called a patient-centered medical home, as the basis for healthcare in Vermont. Now, right now, half of the state, over 450,000 people, are already getting care through patient-centered medical homes. There is an ideology. It includes holistic care. You see your same person, so you see the same person, it's holistic care. It is collaborative. It is self-empowering. When you read the guidelines that any patient-centered medical home is supposed to be upholding, those are in there. You are supposed to be able to sit with your doctor, collaboratively come up with a plan. You're supposed to have a written form of that when you leave. And if you don't, that's something you can certainly ask for. Any practice that's now operating that way is responsible for providing you that care, or they lose their status in the system. So they have selected values. Many of the values are ones that you would totally support. The question is, what's the gap between the clinician starting to do that? As a naturopath, that's how I'm trained, so I already do it. So I was delighted to have these guidelines chosen, because now I can document what I already do in a way that the insurers think is great. But the fact is the medical doctors in the community have not been trained in that way. So you need to go and ask for them to do what you are allowed to do. And that means educating yourself about what the ideology is and what some of the pieces of that patient-centered medical home actually are, and what you are eligible for within that.
Okay, thank you very, very much. Do we have some questions?
And George?
I will start with the question that was addressed to Robin. What will it take to ensure that oral health is included in Green Mountain Care?
So there are two steps before we get from where we are today to Green Mountain Care. The first I talked about earlier, which is coming up with a financing system which will determine an amount of money available to support the system based on estimates and financial modeling. And the second piece is that the administration will bring forward a recommendation to the Green Mountain Care Board on the minimum standard of benefits under Green Mountain Care. What I would like to see as we move forward is that we move to this system where we're paying providers to focus on outcomes and value. And then I think the list of benefits that we're all used to becomes much less of a focus, because then the provider really can focus on what does that patient need. But in the meantime, as an interim step, we still need to have a way for people to know a minimum set of what they can get for what they're paying for. So those are the steps in the process, and then I think it's really going to be at the Green Mountain Care Board where they have the really hard job of balancing coverage and that list of benefits with cost. And so I'm not part of the board, I don't work for the board, so it's difficult for me to say what they would consider, but I do know that they we're very interested in hearing from folks around dental, and there is a lot of clinical evidence to support covering dental. But I think it will come to be a balancing between cost and coverage at some point, and but really more in terms of the criteria would be up to the Green Mountain Care Board, not me or folks in my job.
Richard?
Yeah. Go ahead.
The dental thing. Historically, dentists have been operating outside of every other part of the healthcare system. I mean, there's a little bit of insurance, but this is just my belief that if at some point the Green Mountain Care Board decides to include dental coverage, then it forces the dentist into whatever system we have. You know, maybe the insurance system isn't the best thing right now, but whatever insurance it is, it forces them to act within a system which they've never really had to do before. There's no cost controls, as far as I know, other than through the dental insurance plans, on dentists. So they pretty much are all private practitioners who operate on their own and they have their own business. It's a business model. Until we move the dental model away from that entrepreneur business model, I don't think we're ever going to have affordable dental care, because the state of Vermont isn't going to pay, like $250 for a filling, or and should dentists? And then it gets into the question. They always seem to have new toys every time you go to the dentist, and the latest this and the latest that, and not that that's a bad thing, but maybe some limits wouldn't be such a bad thing either. So all I'm saying is that dental care becomes also, as far as I'm concerned, another complicated political situation.
Spoon, can I just make a comment about what Robin said for 1 sec? One thing I would suggest is, as a teacher, I know that everyone understands bar graphs. Kindergartners use bar graphs. And if the legislature or people in charge of determining this were to sort of put in, like, we put in this much money into dental now, which prevents, then healthcare costs this, or we put in that much money into dental now and healthcare costs that. Because in your digestive system, that's where serotonin is made, that goes to all your nutrition. And so dental is actually preventive healthcare. And using a bar graph, people would begin to understand the effect of not covering dental.
All right, thank you very much, Jackie. We have we have one question for everybody and one question for Robin. We'll go to the one for everybody, just so none of you get too rusty. We'll start with Annie. Why is so much criticism about how the program? Why is there so much criticism about how the program is going to be founded? Who's right? Is there going to be money to fund the program?
So I think you're talking about funding. You want to know why is there so much criticism? I actually have no idea. Let's just answer the question, why is there so much criticism? And I think people are scared. I think we're scared and we are uninformed. We don't know what we actually have. We don't know, as Robin pointed out, we don't know what it costs. We don't know where it's going. And my experience as a clinician is that health is a very, when you're feeling fine, everything is fine. When you're not feeling fine, it's very scary. You don't understand what's going on. And I think the criticism comes from an underlying fear of we're not going to be taken care of. We're not going to be safe when we need to be. We don't feel safe if we can't get care. And so the criticism goes in different places. It's either towards the clinician because they aren't doing their job, or the system because it isn't being paid for. But underlying criticism is because we're scared that we're not safe.
So to answer the second question around is there enough money in the system, yes. So Vermont, over the last, I don't know, since the early 90s, there have been 5 different studies of healthcare reform in the state by 5 different consultants. So different perspective, different point of view, and they all show that you can cover everybody with the same or better benefits for the same or less cost in a system where you are rationalizing it into a system. Right now we have a lot of different drivers in the healthcare system, none of which are streamlined or really organized in a fashion where we know what we're paying for and we're really working towards efficiency. Really, healthcare is the only area that hasn't had any sort of efficiency revolution if you look at all different sorts of industries. Most businesses and nonprofits are looking about how can they deliver whatever they're delivering for in a more efficient way, and that just hasn't yet happened in healthcare. So there's plenty of money in the system. We know that we spend twice as much on healthcare than all the other developed nations, and our outcomes are not better. So we have a lot of room for improvement, and the money's definitely in the system. It's a matter of changing the system so we use the money that we have invested more wisely. I guess I'll pass it to you.
Robin said it all.
Is that it? On that? Okay. If there was another question about where is the money coming from for the program, and I presume from everything I've heard, it's going to be out of our taxes, and probably how the taxes are collected, about whether the taxes will be collected equitably across the state. That is another matter that will go to another area of the government, I guess.
Yes, so the General Assembly, the Vermont State Legislature would be in charge of, they have to actually pass a bill to raise taxes, and so we are talking with as many legislative committees as will have us this session on what is Green Mountain Care, what have we worked on over the past 2 years, what are the cost estimates, how do we get there, because folks at the legislature need to understand where we are and what progress we've made since they last looked at the issue in Act 48 2 years ago. But next year, we will be bringing a single concrete financing program to the legislature. However, as I said earlier, this spring, we come forward with multiple options for legislative and public consideration, because we do need to have a public discussion about what's the right way to raise the money and how, and make sure that people understand that is a replacement of private premiums.
Okay, thank you. Here's a question that is in response to what has already been said here. Richard, it says, as Richard said, dentists have exerted a will of their own. They exert power to exclude treating people. But we also don't have enough dentists. Is there any plan to address this shortage?
Actually, there is. I started working with a group of people a couple of years ago to create a new category of dental provider called dental therapists. They exist in, I think, Minnesota and Alaska. What they are, the best way to describe it is sort of like nurse practitioners for your teeth. And they have a role to play. They can, the role as it's done in these other states has been, they'll do routine dental care, and they'll be able to do some fillings and some simple extractions, if nothing else, and operate under the supervision of a dentist. They've been providing critical dental care in some of the more remote places in Alaska. And now with telemedicine, in a lot of these places, they can have cameras right in the person's mouth and have the dentist, be almost at their side, at least electronically, to help them do things. So when this concept was first proposed, as you might imagine, the Dental Society wasn't really too excited about this. They believed that there were enough. We kept hearing that there's plenty of dentists, that's not the problem, and we got enough dentists here, and we don't need these people. And obviously, there's territory issues, there's income issues, turf issues. However, they've softened up a little over the last couple of years, and our group, well, the group that started this, Dental Health Oral Coalition, I think that's the name. Anyway, they invited the dentists to come to some of the meetings, and so now the opposition has softened it quite a bit, and I'm hoping, I think the bill has been in a committee for the last couple of years, on the wall, as they say. So if this bill passes, then Vermont will be the next state to have these dental therapists. And obviously, what they do, it won't cost you as much as what a dentist does. How that plays out in Vermont will be different than how it played out in Alaska and Minnesota, but I see this as a great possibility for, it's not going to solve every problem for every person in terms of dental care, but it will provide access for people that never had it before. And I'm hoping the bill passes. I don't know I haven't heard much about it this year. I don't know, Mike might know, but.
Okay, Richard, thank you.
Mike has something.
Mike, do you know something?
I can just speak to that, and there is a bill in the Senate and in the House, which we're going to be working on together, and I think there is a lot of support for that. Just while I was sitting here, though, I got an email from a dentist saying, don't do this. I think we're going to get a lot of pushback from dentists on this. I think there is some softening, but I think the walls are just starting to go up. So get in touch with your dentist and tell them, don't feel so threatened about this. Half of Vermonters don't have access to dental care. This is going to help do that. Like I said, there's a bill in the Senate, there's one in the House, and I think we are going to look at it this year.
Thank you. I have a question here, perhaps for Robin. A statement, it begins with a statement. It seems like the ACO, which is the Accountable Care Organization, is that familiar? Yeah. That allows large hospitals to control healthcare profits, is not compatible with a publicly funded health and run healthcare system. What will the role of the ACO be when single payer starts?
Thank you. So for folks who don't know what an ACO is, an accountable care organization is a provider organization where a group of healthcare providers organizes themselves to take a bunch of money from payers to then deliver care in a more flexible way. There are 3 ACOs currently in Vermont. One, which the questioner wrote about, is all of the Vermont hospitals have gotten together to create an entity called OneCare. There is an ACO led by independent primary care practices in the Chittenden County area, and there's a third, which is largely federally qualified health centers. So these are nonprofit health centers, community health centers around the state. So we have 3 different models, and I think this is really a place that's evolving, so it's hard to definitively say what the ACO role will be, because part of what we need to do, because this is a new concept, is see how it works and how it doesn't work, and evaluate it rigorously to make sure we see if this is the model that is the right model for moving towards a system where you can have more flexibility and less micromanagement from payers among healthcare providers. So I can't really say what the role will be because it's an evolving role, and we really need to see how it evolves over the next 3 years.
Thank you. An example. Using obesity as an example, is it both a medical problem but an even greater societal problem? Lifestyle, food, industrial goals, fitness, exercise issues. How could the food industries be made to change?
Wow. I focus on healthcare and healthcare delivery. Food is actually, and I don't want to minimize the question, because obesity and food are very important social determinants of health, and they do really impact on your health. With that said, my area of expertise and focus is really on the healthcare system and not on the larger other systems. But I would actually ask Annie if she had anything to add, because I think as a healthcare provider focused in a more holistic way, you may have some ideas.
Well, certainly I've thought about this, but because I think things like soda and candy ought to just plain be illegal. But I think we have a historical experience here, was if you make something illegal, it just goes underground. I mean, that's what happened with Prohibition. I know, the kids are rolling their eyes. So, I mean, for me, it all comes back to the fact we need some adults too. Yeah. And as part of our definition of care, it needs to have a huge component that involves education around how food affects your body and your mind, and how your body and mind change over time, so that what you do when you're 12 is not the same thing that you can do when you're 45. And why is that the case? I really think that a lot of this has to do with us learning, having a different, I say to people that come to Heart Song all the time that you're culturally disadvantaged in this society to have a clear understanding of health, because we've not been raised, you've not been taught in a way that really helps you understand how health happens, that it's our responsibility, not somebody else's, and it requires a completely different way of looking at what health is and what your role is in determining your own health in order for things to change. It's about changing the whole way we think about ourselves.
I'll make one comment. I learned something today that kind of surprised me, but now once I've heard it, I want everybody to hear about it now. So,
And there's a microphone, so it's a good.
oh, okay, yeah. Turns out, and I don't know the actual statistics, but this is anecdotal from people that I work with, healthcare people. A lot of people who go into the prison system in Vermont they go in with a relatively ideal body weight, or close to it, and when they come out, they're obese with type 2 diabetes. Well, apparently, this is a fairly common problem, which I didn't know about. And if it really is a problem, then this would be a perfect place for the state of Vermont to start getting into the controlling some kind of food programs, or whatever you call it. I don't know what prison diets are like. I have no clue. I don't know any details yet, but now that I've heard about this, I want to find out more. And if, in fact, this is a statistically significant issue, then it's something we could address. Because I'm working, like, for example, I work with a diabetes educator, and today, the first time I heard him tell me, he says, oh yeah, I deal with people all the time coming out of prison. They never had diabetes, they never were overweight, and now they're obese, and the day they get out of jail, they're on insulin, and their whole life had changed, and so just something worth looking into.
All righty, thank you. If I may, this wasn't in the script here, but listening to the conversation, I can't resist throwing in my own 2 cents.
Write a card?
I just can't. I'm not a scientist. I'm not a doctor, a medical person, or anything. But just as a generally informed person, I can't imagine that I could be possibly ingesting all of the chemicals that I do without harm being done to my body. I have no scientific evidence, but I can't imagine that those chemicals are not doing harm. getting pure food is pretty difficult. It can be expensive. But there's a great movement afoot here in this very town to garden. And most people with a little bit of ingenuity, if not luck that they have it already, do have a small piece of ground. And anything you can grow as cleanly as you can is going to help. And I'd like to say, we now have a town where there's probably 100 different houses raising their own chickens. I think this town could raise all its own food if it needed to, if it had to. And it could be a lot purer than what we're forced to buy. So that's my comment. And I always wished that kids could come out of school knowing a little bit more than they do, but that's the education part of it. It's improving a little bit, but it's clearly not as good as it should be. One more question, and I think maybe that'll be it. Oh, they keep going.
Any other questions?
8 o'clock is our absolute limit, but we're not required to go that long. We've been here for a while anyway. Why was the dental group treated differently than any other medical group? Well, Richard, you're at it again.
Well, no, I don't know what that question's applying.
I'm not,
Maybe, I think it's a Robin question, but it's about state priorities. Is that what the question is?
No.
I read only what I had.
Is this your question?
Yes.
What do you mean?
Why did the dental group either not be asked to join or refuse to join the group that
Oh, the coalition? No, we invited the dental society. Actually, their representatives came to the first few meetings we had. They sent their lobbyists, and then, interestingly, what happened after that, the next few meetings, dentists showed up.
No, but I'm
Right.
talking about when
Right.
did this all start? I
Right.
mean, we're talking about this great big.
I'm not sure I
I think,
understand.
I think I understand the
what?
question. Tell me if I'm right. You said before that you were talking about the history of how the dentists were sort of separate from the rest of the medical
Oh,
establishment.
yeah?
And isn't the question like, how did that ever happen? Like how,
Yes,
why is it that like historically the dentists were not sort of incorporated in the,
I have an answer, I think. So, it goes back to how health insurance was first created, which is, at one point in our history, we had a wage freeze. And so when employers wanted to compete for employees, they started offering hospital benefits. So health insurance actually evolved the same way that Medicare is structured. So hospital benefits were the first types of healthcare coverage that was provided through by an employer-based insurance system. Then that got expanded to physician benefits, and then just as a historical accident, vision and dental have always been separate. And actually mental health as well. It's like if it's in your head, it's not covered. It doesn't really make sense. But I think it's really because, exactly, you're covered from the neck down. It's really true. It's really a historical accident of how health insurance in this country evolved as a market-based commodity through an employer-based system, and not as a coverage social benefit like in most other development countries. So other than that, that's the best I can do on the history.
Yeah, and I think if you look at the history of just market-based medicine, dental care is the prime example of what happens if you have unbridled, if something is a commodity that has very little regulation and it's a healthcare service. Dental care is the perfect example. It's a good example of why we shouldn't move in that direction for the rest of healthcare, at least from my perspective.
Okay, I have one more question, again for Robin. You mentioned social determinants of health. Do you think we can set an example with our healthcare systems so we can change our other systems so people can access food, housing, heat, etc.? How can we be responsible for our own health if we have to worry about making ends meet and just surviving?
Thanks. You know, I think we certainly can strive as we change healthcare to be a model for other systems. But as Richard said, it's a political process. So it is a process of compromise over time. And I really loved the Dr. King quote at the beginning, because it really highlights for me that there is no end. You're going to take steps forward and steps forward and steps forward, but thinking about it as an all or nothing, or we're going to get there and then we're done, is just not going to happen. We really need to think of it as an evolving process. So I hope that we can do that in healthcare. I don't think we'll manage it in, you know, the next step. We have to keep trying until we get there. And then I'm going to just ask myself a question, because it usually comes up, and it didn't come up today, but usually people ask, but what about Medicare? How does Medicare fit into it? And I'd like to make sure we talk about Medicare a little bit, because I hear from more people on Medicare than any other group of people in the state of Vermont, and that's because, for the most part, folks on Medicare appreciate that they have coverage in a different way than that they previously maybe didn't have or had employer-sponsored coverage. And so the way that we are approaching Medicare currently, under the way the Vermont law is written, is that everyone on Medicare would maintain Medicare as their primary coverage, but we're working on how Green Mountain Care could provide supplemental or secondary coverage for folks, so that everyone is in the system and everyone contributes. That will be a subject of debate with the legislature, I expect, because there are a lot of folks on Medicare who are afraid of losing Medicare, or afraid that the state is somehow going to make it worse for them, and that's absolutely not the intention, but I understand when you have that kind of security, why you would be afraid of losing it. So I just wanted to add that, because that's usually number one question we get.
All righty, thank you very much. And that seems
Can I
to,
just add something?
wait, one last comment from
No,
Davis.
I wanted to address that social determinants question.
Oh, good.
Because I think that, you know, the person, obviously, people in this country have a fear of not getting what they need, and it's not just healthcare, it's everything else. So if you look at the other countries around the world that have, like I mentioned, had conversations not only about healthcare, but about all the social determinants of living, not just health, but living, they've all decided that, not all, but most of these countries have decided that it's worth paying a lot more in taxes to have that kind of security. We don't want to do that. And I don't know how the hell we're going to do that, how we'll ever have any kind of security if we don't make a decision. If we want equality, we need to make the decision that it's worth paying more in taxes, because, and I'm not just talking about healthcare, I'm talking about all of the issues that we face every day. The bottom line is it costs money. So would you rather spend your money subsidizing oil companies and drug companies, or would you rather spend your money paying higher taxes so that your life can be better? You know, I think that's a whole nother conversation that I can't see it ever happening in this country, but it would be nice if we ever did have that kind of conversation and actually had people saying, yes, I want to pay more in taxes because I want everybody's life to be better.
Okay. I would like to thank our panel, Richard Davis, Robin Lunge, Onye Hawkinson. Sorry. Thank you very much for all of your time. Thank you, everybody, for showing up and for making this a very special event. Is there a... Oh, wait a minute, there's some final concluding remarks. Did a great job.
I hope that we are leaving here with a better sense of how we will move forward with building a healthcare system based on human rights principles. Right now, we are working together to create a new universal healthcare system that ensures all needed care instead of limited coverage benefits, and an equitable financing plan with progressive taxation. At the same time, we acknowledge that this is only one essential step on the path to making sure all of us can realize our fundamental human rights and meet our fundamental human needs. How can we do this? We can't do it by staying silent. We can't do it by holding on tightly to whatever small thing we have for now. We can't do it alone. We can create lasting change by sharing our voices and stories and seeing the commonalities, in our individual struggles. Together we must stand up to those who seek to turn human needs into a mechanism for profits. Together we can work to create meaningful, lasting change to ensure that all of us can access our fundamental human rights and live in dignity. We must put people first. Here's what you can do right now to be part of this movement. Sign a paid sick day petition to show the legislator and governor that the people of Vermont believe all workers have the right to take care of their own health or that of ill family members without retaliation, fear of losing a job, or loss of a critical day of pay. If you haven't yet signed the petition, see one of the people raising their hands. Our organizing committee meets every other Tuesday from 6 to 8 at the Root Social Justice Center in the Whetstone Studios building on William Street. Our next meeting is tomorrow, January 28th. 21st, sorry. I'm really ahead of myself. If you want to learn more or get more involved, come to a meeting. If you have questions, please feel free to talk with any of us after the forum. Mark your calendar for the Healthcare is a Human Right Lobby Day on January 30th at the State House. We'll have carpooling going up from Brattleboro, and you can sign up tonight for carpooling. Would someone please hold up the carpool sign up?
You can see me if you want to carpool, because I'm driving up.
That's good. Corporate lobbyists are out in force, and they have big bucks. We don't have big bucks, but we have lots of people who are affected by decisions made about our health care. So we lobby for the human right to health care by showing up. If you can't make it on January 30th, but want to go on another day, our People's Team is our eyes and ears on the ground, sitting in on committee meetings to be sure that we are visible and to keep ourselves informed about what is going on in Montpelier. Again, there are carpools, see Ellen, if you are interested. Thank you all very much.
So everybody, in final closing, I just want to give our thank you to everybody who contributed to today's event. I want to thank Morningstar, who earlier was wonderful in playing the guitar and singing for us today, creating a little bit of ambiance and bringing the arts to our movement. Again, I want to thank our panel, Richard Davis, Onye Hawkinson, and Robin Lunge. I want to thank all of our health screen clinics, Dr. Jane Cat Fields, Dr. Maggie Newton, Susan Sutton, Cindy Hibbard, Deborah Solnick, and Joyce Judras. I want to thank our wonderful testifiers, Maddie Solomon, Lynn Akey, and Jackie Gould. I want to thank our child care providers for helping out with us, Debbie Reed-Xavier, Irisha Fisher, Brendan Fisher, Sarah, I didn't catch Sarah's last name, and Caitlin Ford. And again, thank you to media with Kip and Maria and all Commons for being here. Thank you to our interpreters, Janet and Lori. Thank you for making this accessible to our community. That's extremely important to us. I also want to again thank St. Michael's Church and Jeannie and John for setting up everything, and the Brattleboro Retreat and many other local businesses who helped contribute tonight. Again, thank you all for coming to our Healthcare is a Human Right community meeting, and have a good night, and remember Dr. Luther King Jr. Thank you.